I will delve into the target concept for what I want you guys to take from this session. But first, I want to check if you are awake, and we are going to have a look at a video where I injured myself. I may have showed this to you already, but it has some relevance to what I want to discuss today. Okay, this was during some filming 2 years ago, playing around with some stuff that I wasn't training at the time. I'll watch that again in case you missed that. So I was doing some high load rotational shoulder rehabilitation and worked my hands in closer here to release and rotate on one arm. And as I did so, full rupture of my pec major, which within 1 hour had the classic big avulsion, hematoma and bruise all down the mid bicep, because the pec inserts underneath the bicep on the humerus underneath, and I couldn't perform pressing of the arm. I've got some videos on my YouTube because the pec major was totally ruptured. And interesting mix in the research around whether you go for surgery for that or manage it conservatively. Research is pretty similar when you look at ruptured Achilles. When you look at any one tissue that's ruptured, you can often see that you can do things conservatively as well. But when there is a maximal performance perspective involved, there seems to be some benefit to being able to have the pec major, particularly with my interests of sport and training. So I went through surgery. Now, I managed to get surgery in within 4 days of that, and rehab for me started the day of surgery. Okay, so how do we engage with pain in my shoulder there to be able to facilitate through a rehab pathway? Taking my shoulder in the acute phases, so the first 2 weeks, out into any stretch of the pec or into any contraction of the pec, caused my surgical incision to be painful. It hurt. You, as my healthcare professional, what information are you going to be taking from that pain of my acute major tissue-based injury going into that tissue hurts 1 week after surgery? What's going to be your advice to me around pain in that instance? Anybody? Should I just ignore pain and try and get back and do that exercise? Karen.
Yes, hi, good morning.
Morning.
So I've got a very active young man who likes his physical challenges and is now confronted with some pain 1 week after surgery. Correct?
Surgery on what? So you're just reviewing this situation,
yeah? So
yeah?
just to get a good handle that You know, I've got somebody who really likes to be physically active, and they're kind of, you know, they're getting confused as to why it might hurt 1 week after surgery.
So I will make it even simpler. I've given you the exact situation. I've even come to you and showed you the video, because that was the video of the injury.
Yeah.
Often you're not going to get that. You're going to get a description.
Yeah.
But I film all my training, so it means that I can help you because you can see exactly how it happened.
Yeah.
And I've had to go through surgery, but I want to get going again. And it hurts when I move my shoulder.
Yep.
What is your information there around it's hurting when I move the shoulder? Do I push through and just crack on, no pain, no gain, or is there a different approach that you might inform me of?
I'm going to go with a different approach and say we need to keep that shoulder steady now. It needs to go through its natural history. It needs to, you know, you've had some major trauma. We're not talking about learnt pain. We're talking about actual tissue trauma. So perhaps it would be better to leave that whole area alone, and maybe we can do movement somewhere else, so that, you know, because you're obviously going to want to move. We don't want you sat at home doing nothing, but perhaps you could have a little bit more focus on legs, but probably leave that area alone until the tissue has repaired.
Fantastic. Thank you very much, Karen. And I think that I might come to you when I get my next injury to try and hold me back and get me safely back to the things that I need to do. But fundamentally what you have just described there is that the pain in my shoulder in an acute tissue-based mechanism is helpful in saying, don't do that for a while. Back off. Okay? Or in other words, that pain is adaptive. That pain is telling us that there's a danger, there's a threat, and we're going to listen to that, and we're going to back off whilst we let the tissue healing phases run their course, which is going to be the inflammatory process, where we can see that. Look at this, look at the bleeding, let's pull up the video. You can see, and we've gone through a major traumatic tissue-based mechanism that's going to have to go through bleeding, inflammation. We've had surgery or not to be able to support what we want that structure to be able to do, and now we're going to have to go through remodeling and scarring, and we can look at the literature around what our diagnosis is, around what the natural history might be there, and we can then bring activity in as we go through those phases, because pain will hopefully tail off as those tissues settle down. Is that sort of what you were thinking there, Karen?
Yeah, yes, and in much more scientific terms, yes, I would be thinking of the pain. This is appropriate levels of pain. This is the type of pain that we take a lot of notice of, and we don't want to happen, so we rest it. This is the pain that tells you to rest, and this is the time we listen to that. So yeah. Fantastic.
And that's what I want you to be able to, the language, and what I'm going to title this session is going to be adaptive and maladaptive pain. Okay, so adaptive is, this is telling us that it's not ready to load yet, and we're going to listen to that. And as you said there, you've looked at me and you said, right, we're going to do some other things in the meantime. You can still train legs, you can still do aerobic activity, and we're going to, as your clinician, we're going to creatively say, we're going to not load this up for this long, maybe the first week, and we're going to do other things. And that is ultimately nice and logical, and rehab is much, much easier when we're dealing with adaptive pain that is tissue-based, because most people will be familiar with a sprained ankle and the inflammation, the swelling, and the mechanism. I rolled my ankle. There was that point when it started. I can see the symptoms. When I load them, it hurts. That is very much a back off, calm things down, and get going gradually as those tissue healing phases pass. Now, what's much more challenging as a person to go through, and as a healthcare professional, is when pain is potentially not a measure of the tissue damage, and even in acute, by the way, it's not a direct measure of tissue damage, but it's adaptive in that we can say, we're going to back off and listen to that. But often with people who have had neck and back pain, for example, or headaches, we don't have a tissue-based explanation. We have a pain issue, and that is fundamentally, the terminology I want to introduce here is maladaptive. In that, we can't just say we're going to back off and we're going to wait and see. We know that if that was going to help, that it would have probably helped by now. This is maybe going on for 6 months, a year. We need to find a different way to do things, and we need to be able to get going. And that's where our education around pain, being an alarm system and how different things can set it off, helps us to be able to work with this idea that this pain experience is potentially overprotective, and we need to be able to engage with an agreed amount of discomfort to be able to get you going to the things that are important to you. Maladaptive. That's where last session, my favorite clinical reasoning component of rehab is when we can get to then trying to find novel ways to be able to let someone's nervous system be able to experience movement based on the different theories you talked about last session. Okay, so what sits somewhere between adaptive and maladaptive is the really confusing one in between, which is nerve root, which is your, in terms of neck and back presentations, you've got your 90 to 95% that are your non-specific in terms of its cause, and we have then the 5 to 10%, which is our neuropathic, or it's our nerve root, neck or low back, that has the potentially associated leg symptoms that come with it. And that in of itself is a hybrid between the two, because we do have a tissue-based injury, but the injury this time is not to the tissues, it's to the alarm system that's carrying the information from the tissues. It's in the nerve root, and often actually to get nerve root presentation, there doesn't even need to be an injury to the nerve root, there just has to be inflammation around the nerve root, or experimentally you can just put inflammatory mediators onto a nerve root and that will cause the symptoms of a nerve radiculopathy. And in terms of then being able to take someone who's come to you with your nerve root presentation and clinically reason, is this leg pain and back pain that is coming with this adaptive or maladaptive? So adaptive, like Karen said there, okay, we're going to back off and wait and see. Well, if we're doing that with a nerve, with an ankle, you can offload and you can get on with life. If you do it with my shoulder, I can put it in a sling and I can focus on legs. If you're talking about your low back, that pretty much takes everything out. You can't just summon somebody to a wheelchair. And in fact, that as an approach has been shown to be not the best, and we're going to put up the nice guidelines afterwards. So the fact that the injury is to the nerve root in itself, and the extent of the pain that goes all the way down the leg, potentially in the back as well, to just putting inflammatory mediators on the nerve root is so disproportionate to the size of the injury that we could argue, and very prominent figures in our industry and field like Louie Gifford, who is going to be in your resources from this session, that nerve root pain is maladaptive from the start. So even with an acute disc herniation, which is going to be one of the most common ways that we could get a sudden traumatic injury to the nerve root, the pain experience, and if you've spoken to anybody who's had it, it is far more disabling than my shoulder. As I said, I can put a sling and focus on other things for a while. Ankle, you can limp around and you can offload that for a while, but you can get on with other stuff. But once you have a nerve root in your low back that is lit up by bending forward, it stops everything. And that is disproportionate from the start. It's maladaptive to the size of the injury. Doesn't downplay the experience, but in terms of our clinical reasoning, it is an important grasp that I want to get you guys thinking about by the end of this session. And I've wrote an article on our website to help me and to help us to be able to navigate this whole idea around whether nerve root is adaptive or maladaptive. And I'm going to share that and take you through it as a resource. It will also be uploaded to Blackboard. Share. Sorry, it's already on here. Okay. So, is there a situation where increased sensitization is beneficial for the person? Okay, because sensitization we've talked about a lot with persistent pains, as it's something that can become overprotective. But it's designed, and we've evolved the ability to have a sensitization because it will be adaptive and helpful in terms of telling us to offload tissues. But let's recall the definition of neuropathic pain, which is pain arising as a direct consequence of a lesion or disease affecting the somatosensory system. The nervous system is what relays nociceptive impulses to the brain and potentially causes a pain experience. In the instance of spraining an ankle, these signals are absolutely adaptive, or as Karen said there with my shoulder, the pain on my shoulder was adaptive and telling me to have a protective response to enable healing to take place. Adrian Liu, who's the author of Pain Neuroscience Education, that you guys have got for being able to get these target concepts across, uses the metaphor of an alarm system, which I've introduced with you guys and is a pretty universal concept now for being able to describe how pain works. Louie Gifford, who is these books here that I will be uploading, really was one of the most dynamic figures in musculoskeletal rehabilitation in the 90s. He's a British physio that built his trade over in Australia with David Butler and the NOI guy, what went on to become the NOI guys, and Laura Mosley, and Louie Gifford was really around the time of Gordon Waddell, and really trying to drive this pain experience as a biopsychosocial person-centered approach. And he was ahead of his time. Unfortunately, he's dead now, and it was in the process of writing these books that was when he was actually dying from cancer, and he reconceptualized the fact that he had about a year to live to turn his career into a story that really set the scene for what we now would call contemporary evidence-based practice. An amazing man, and those books I highly recommend, because for those of you who are interested in developing your clinical reasoning, that will be extracurricular reading that will transcend revision and leisure, because it's one of probably the single most important resources in my last 10 years. But anyway, Louie Gifford argued that any lesion to the nervous system, like a disc injury, will have some component as being maladaptive, as the injury is to the system that should be carrying the information about danger. Okay, so adaptive pain is helpful, and it produces behavior that promotes healing recovery. And as we talked about there before with Karen, if she was managing me there with my shoulder, if she can just entertain me, if she can give me enough education and reason to make sure I back off my shoulder for long enough, that will heal, and then she'll basically be able to let me go, and I can build myself back up, hopefully in a nice and graded way, that I don't go and exceed my tissue tolerance again. But that's often what happens a lot in rehab, and especially in physiotherapy, is that it's just load balancing, stopping someone do something for a period of time, and actually the reloading often is just, people are just left to go and sort of figure that out on their own once pain has gone, and that they can just sort of start get going. And that's again going to come down to you as an individual clinician as to whether you're going to be in more the pay-as-you-go, drop in one session at a time, or if you're going to work maybe the way that I've chosen to work, and Paul, which is where we work over periods of time to be able to calm stuff down, but then also build stuff back up. rather than handing the reload and stuff over to a personal trainer or a strength and conditioning coach, can we as healthcare professionals be able to grade someone back up to what it is that they want to be able to do, whether it's work or whether it's sport? And that's going to come down to your investment in yourself to be able to adapt to different people and what their goals are. I digress. Maladaptive pain is unhelpful pain that tends to be out of proportion to the actual tissue damage and which persists long after the tissues have healed, so that the pain becomes the problem rather than the tissues from which the pain comes. Okay, and that's a really important bit of terminology that as Karen was doing a great job at explaining how she's managed me. What I want you guys to be using is these really clear terminology in your notes, in your thought process around when you're working with your patients now. You know, is this pain adaptive or maladaptive? Really, really important in being able to underpin your clinical reasoning. The research and management of chronic pain and associated disorders. So this is your neck pain, pelvic pain, widespread pain, something in my shoulder hurts pain, chronic fatigue syndrome, tension headaches, osteoarthritis, tennis elbow, non-specific arm pain, patellar tendinopathy, or any tendinopathy. We are going to be covering tendinopathy. I've already filmed a 2-hour webinar for the third years, but I've created programs for load management, but sensitivity management is equally important in dealing with those presentations, because a large part of that is central pain or nociplastic modulation or sensitization. And some degree of central pain sensitization in response to acute injury may, however, be considered adaptive in facilitating recovery. You know, we haven't evolved sensitization by accident. If you were, who here, just pop it into the box, was in my peripheral sensitization session or has seen it on Blackboard? I'm pretty sure some in this group had the peripheral sensitization session. Martin, that means you and the rest of your group had that one. Can you remember the experiment that I gave you for being able to demonstrate that with patients? How peripheral sensitization can be visually demonstrated?
No, I can't remember the example you used. I can make an example of myself probably, but sorry. And the fact that I saw it doesn't mean that my whole group saw it. I don't know when I saw it exactly, so sorry.
Okay, no problem. But I'm pretty sure that half of this group had that lecture with me. Is that not true? If it's not, then you can review that on Blackboard. But just to summarize briefly, if you were to have a paperclip now, guys, or you had a pen and you click it so that you've just got the end but no pen, and you were to just scrape it along your arm for about 2 inches, you could do that now and leave that, right? And what's going to happen is over the next 1 minute to 2 minutes is that scrape that you just put onto your arm will develop a spreading redness. You will see that there will become a scratch. If you were to have scratched it lightly, it won't be there now, but over the next minute or two, a red line will appear. And what's happening there is your neuroimmune system is identifying, it's taking the input that we're putting in there, and it's going to then increase or release the inflammatory neuroimmune process that is going to sensitize that area for being able to protect it, to say, hang on, that area has just been stressed. Let's make that a bit more sensitive so that we can let that calm down and settle down. And that's peripheral sensitization in a nutshell, and our neuroimmune does that to be able to tell us that your shoulder's sore. This is happening not just in our skin, it can happen in all of our tissues, to be able to sensitize it, to make us back off. Okay, that is a really important point. But, sorry, that is a really important point. But when those changes, which can also happen centrally, continue and persist beyond tissue healing times, those changes can in of themselves become the problem. Okay, so that's often, and that's a part of our assessment with persistent so tendinopathies in particular. Some degree of central pain sensitization in response to acute injury may, however, be considered adaptive, and that's what I just illustrated there. In this instance, sensitization of local tissues is a feature of an acute inflammatory process. And in the example of an ankle sprain, the responsiveness of polymodal nociceptive endings, we'll talk about in a second, is enhanced by various sources, such as serotonin, bradykinin, plasmin, prostaglandins, substance P, the things that seem to be important in the mechanisms of pain. So if we have, I've filmed this and videos for you to test this in your tendinopathy lecture. We can test for hyperalgesia, which is, there's a series of tests that we do with temperature, ice cube, wind up, temporal summation. But we haven't covered that yet. But what I just illustrated was primary hyperalgesia, which would be your tissues sensitizing to be able to protect you. Peripheral sensitization is the other word. That is adaptive. That can be helpful in offloading our tissues. Polymodal nociceptors refer to the direction of impulse. So everything that we've gone through up to this point has been around danger messages or nociceptors being in the tissue, sampling our tissues, and then sending information in that could potentially go on to be given or to drive a pain experience, potentially. Okay, we talked last week how it could be, we don't need nociception, it could be a learned, once we've wired and we could have maybe associated a movement pattern into a neural signature, it could be hearing something that sets off a pain experience. So tissue damage is just, or nociception is not necessary for or required for a pain experience, but often it is involved. But the direction of the tissues into the nervous system is what we call orthodromic. Okay, so that's where the information is coming in, or we would call it an afferent direction. What a lot of people often miss is the fact that even though afferent nerves carry information in, they also carry information back the other way, or what we call antidromic. And this is how we explain often nerve root or inflammation in tissues that won't necessarily settle down. So I'm just going to come back to here. This is an example where most people, like my arm, will be able to connect to the inflammation, the bleeding, the swelling that we will get with a tissue-based injury. Okay, and if you'd have seen my bicep when I ruptured my pec, that came up within an hour. That makes sense, and it is nice and easy to explain, and most people understand that that's there trying to protect you. Getting the swell into the area, all of those things are there to try and protect us. And the direction of pain is often described, and we understand it as coming from, if we look at talking about the ankle here, nociception or danger messages carrying information in. That would be, as Karen said, loading that tissue's there, it's setting off the danger receptors, it's adaptive, back off. Let those tissues settle down. Little experiment for you guys though is going to be here now, and I would get my patient to be able to do this as well, is I want you to just get your ulnar nerve, so you guys should hopefully be able to locate that. If I described it to a patient, I'd say in this bony nodule here, medial epicondyle, olecranon, in between there's going to be a little bit of spaghetti. I can find mine straight away, and I want you to, we call that our ulnar nerve. Now I want you to be able to just play with that and see if you can just press that, and what you'll soon find is that you can produce some symptoms down in your little finger. If you press that, or if you can't do that, you will know when you hit your not so funny bone. You'll hit it and you'll feel that down into your hand, and most patients will be familiar with that. But whilst you're also able to press this nerve here, you're able to feel symptoms down in the hand. You're also aware, and you can feel it as you're touching it here, so it's sending information here as well. So it's a really nice example, this is in the neurogenic inflammation part of your pain neuroscience education, of how these nerves are carrying information not just in, but also out. Information travels the other way on afferent nerves as well. So to be able to demonstrate that on on the example of the ankle is that we have loading of the ankle or loading of my shoulder that then sends this red line in, which is nociception, danger messages, that is saying that this is potentially a problem. Information comes out, I have a pain experience, adapt my behavior. And then we also have this efferent, or it's not efferent, what I'm demonstrating here. This is still all within your afferent fibers, where we then have information going the opposite way that then releases the neuroimmune response that we just saw with scratching of the arm, the neuroimmune inflammation, and also mediates inflammation in tissue-based injury as well. Being able to reduce mast cells, being able to cause swelling, being able to get our immune system there. That is a really important part of what our nervous system does and our immune system, how it works together. Now, don't take this example here where we're pressing the ulnar nerve. Let's take it a little bit more proximal and do the same thing on a nerve root. And that's often what will be the hallmark of the presentation when someone comes with a radiculopathy, is the fact that they've had an injury here, not just pressing it, but an injury and inflammatory mediators around there that gives them the presentation of arm pain, or what we would call a radiculopathy, or leg pain if this is happening in the nerve root in the lower back. And being able to use this to be able to illustrate and demonstrate how when we injury to a nerve root, the injury is to the alarm system itself. So there is a disproportionate experience to the amount of damage. Again, being able to connect to the fact that this is your individual experience, but the tissue damage here causing that radiculopathy is by an injury to the alarm system itself. And that's really important to be able to normalize the fact that it's a very debilitating experience. It'll stop people doing things that are very important to them. It will make them miserable, because often it's a slow process to be able to get that back. But firstly, coming to terms or accepting the idea around this is my alarm system that's injured, that helps normalize the fact that we can have swelling in the hand, we can have some bruising, we can have things that our nervous system is able to, if we can explain neurogenic inflammation, it also helps to be able to explain how we can have the symptoms of radiculopathy. And being able to then do that enables us to connect then to everything else that we've been covering in this course, so that the fact that the alarm system has become injured, well, the rest of the alarm system then is also still attached. So your brain, your thoughts, your emotions, these are all impulses too, and these all affect turning the nervous system up or down. And being able to address specific things that are relevant for someone who has radiculopathy, which we're going to talk about in a second, but then also being able to connect to everything else that we've done so far. And as I've been saying, there's a lot of these mechanisms we've been describing for persistent pain are equally relevant for acute pain, because it doesn't say anywhere in the guidelines that we should be doing the absolute minimum in terms of what we give somebody as part of their rehabilitation. If someone has a specific injury like a nerve root, there's going to be some specific exercises that we are going to be wanting to do as part of that. But we should also be still looking to create a person-centered approach. So all the general themes that we've gone through in this course so far are going to be needed to be connected to the person that's attached to the nerve root, just like you would do if you were working on my shoulder and Karen said from the start, right, what's important to you? We're not going to load that for a while. What else can we do? We can train legs, and what me and Paul and what the university we want to be seeing is how you bring these individualized specific programs to life with the person. Okay, so that's how I would explain neurogenic inflammation and how injury to the nerve root is an injury to the alarm system itself to try and normalize the experience, because it is vastly disproportionate often to the size of the injury, which is often a big surprise to people, because a lot of people's experience will be the more the injury. And in fact, when we injure the nervous system, when you injure a nerve root, you get an enormous pain experience that is actually nowhere near as big as a mechanism of injury as what I put on the start of my shoulder. And I had a far less painful experience with that than people will generally have when they have a nerve root pain. So that's that's neurogenic information as a way of trying to describe how we can have information that carries both ways within our nervous system. And secondary hyperalgesia refers to increased responsiveness of the dorsal horn neurons localized in the primary spinal segment of this primary source of nociception. So then you're talking about your central nociplastic changes that we've been looking at with our calming nerve session. We looked at how descending inhibition affects the changes at the dorsal horn. We have neuroimmune adaptations and changes into receptors as to how much nociception can pass through. These things are what we call nociplastic or central changes, and those will, if they continue, can often last a lot longer than tissue-based healing times, which is why the natural history of a nerve root will often go on beyond that 6 months of tissue healing that we would tend for most things to settle down. Often, and as Louie Gifford will describe, often nerve roots, we can get them back with this toe-bone effect. Some days are going to be worse, some days are going to be better, but often they're never the same again. And that's being able to normalize and come to terms with the fact that it's an injury to the nerve root that has taken place. So the closing notes that I put on here were that sensitization is an important thing for healthcare professionals dealing with pain to not only understand, but to assess and manage. It's important clinically to understand that adaptive pain responses might include an antalgic gait or an awkward posture, and that they could be beneficial to offload injured tissues while they heal. At this point here, I would connect to something that I was teaching 2 weeks ago with the third years, which is Mckenzie. Are you guys in this group? I can't remember if I taught you or if you covered that last year, but Mckenzie Technique. Does that mean anything for you guys? Cool. So Mckenzie is something that has, it was born out of physiotherapy, and it was a system designed to try and work with back and leg pain. Okay, it was something that was designed way back, and the initial narrative around it was that if we have a disc injury or derangement, as it would be described, that we would be able to find a directional preference of repeated movements, so lateral flex, forward flex, backward flex, to tell us if we can move the symptoms of someone's leg pain either proximal or distal. If we could move the symptoms proximal, then we were centralizing someone's disc derangement. If their leg pain was getting further past the knee, then we were peripheralizing, and that as a mechanism has been robustly debunked in terms of the plausibility of being able to move discal material by repeated movements. The idea of flexing causes the nuclear material in discs to go posteriorly as a consistent, every time you do it that happens, has just been so robustly debunked, because you're equally likely to have discal material moving anterior when you flex. And again, aligning contemporary understanding around discs, you can injure your discs in your spine the same way as I could rupture my pec here, the same way that you can sprain your ankle. There's a big stigma and a big mystique around the spine because it's deep and we can't easily access it and manually palpate it. But being able to move the discal material by repeated movements is not plausible. Injure a disc, 3 months time it will be 50% smaller, 9 months time it will probably be resorbed, and there will be other different bulges. If you want the research there, I'm not sure, is Paul on this lecture? Paul's not on this lecture. We've put all the materials for the contemporary challenge to Mckenzie Martin in the year 3 module. You will be absolutely invited to be able to check it all out. We've put reviews on there of people who have been onto the course, because what Mckenzie has tried to do is update the narrative to be able to keep the idea of the concept for directional preference, but then change the narrative around how it's affecting symptoms. And ultimately what it is doing is symptom modification, and being able to have tracks of exercises. So the classic Mckenzie exercises would be extension. So your sort of cobra position where you're lying down and you can back bend, and doing that in different directions. They're going to be helpful, but the narrative around it, you should be aware that has been very heavily challenged. And ultimately that's when they faced the questions by someone who actually asked those on the course. Paul's put the materials that if you can't get access to this, contact Paul. He will be able to tell you, give the information directly. Or I will put it on. I'll put it on with this, because you won't be the only person who will want to maybe see it. I'll maybe see if I can get it onto this module. Would that be helpful, Martin, if I put it on with my stuff here? Cool. But anyway, what I was leading to there was big part of the Mckenzie approach with this would be, so someone comes in with an antalgic, so they've got a side shift posture, leg pain down the leg, and they are in this posture, and they're coming in and telling you that they've got leg pain. Okay, in terms of, you know, they're describing that they've just had a mechanism. They maybe don't have a video like I have, because they don't film all their training or their daily life. They are describing that they were lifting up something heavy and they've then experienced this leg pain, or what will often happen will be that it will have come on 2, 3, 4 days later than when they lifted something heavy. And that's where appreciating and understanding that antidromic mechanism for how neuroimmune inflammation happens can take 3 or 4 days for the neuroinflammatory chemicals to work down the nerve to then give a pain experience. And often it is 3 or 4 days later that someone could report the leg pain. I'll offer this question now. You know, so someone's described, so just like I did, I come in at the start, told you my history, clear tissue-based damage, mechanism, had surgery, and you guys agreed that it was probably adaptive to listen to that and back off it for a while. Now I'm telling you that I've lifted something heavy and I'm coming in and I've got this side shift antalgic posture and I've got leg pain down here and I lifted something heavy. In this instance now, what is your clinical reasoning that my posture is adaptive or maladaptive? You know, maybe you don't have to answer here on camera, but I want you to be starting to think around, you know, is this, you know, we often treat the back different to the shoulder or to the ankle. You know, is this posture, this side posture, offloading tissues that are sensitized because we've got a disc injury that is helping offload some tissues? And do I want to be able to change that, or do I want to be able to say that's potentially helpful? You figured out that position that's most comfortable, and we're going to build from there. Or what Mckenzie might try and apply is some of the procedures for trying to correct the alignment to bring back to straight. You know, that's for you to be able to consider and weigh up whether you would take that presentation, which might be your nerve route, as adaptive or maladaptive. And that will have implications as to how you might go about the rehabilitation pathway and your clinical reasoning. So let's take that one on a little bit further. So now this time I'm coming to you and I'm saying I'm still like this, and I've got a little bit of leg pain, but it's maybe not as bad, and this has been now 6 months. Is my posture, is the way that I'm offloading now adaptive or maladaptive? Again, there's not going to be a correct answer there, but there will be your clinical reasoning at some point that will have maybe gone from an adaptive posture that would maybe influence that. That's cool. That's offloading tissues that want to settle down to. Well, if we're now learning and we're finding these new habits that we need to probably break because that may be now no longer serving an adaptive process, how do we get that back? So having an awareness of some of the Mckenzie techniques might be a beneficial way to return somebody to that. And that's an important process that I want you to be jotting down in terms of dealing with the pain presentations and whether something's adaptive or maladaptive. My final notes on this session here, with regard to sensitization, this has got an evolutionary beneficial origin to sensitize tissues and prevent excess loading while they heal. The ability to distinguish between peripheral sensitization, so primary hyperalgesia, and central or nociplastic hyperalgesia is extremely important for the reasons that I just discussed there, because how you would go about dealing with adaptive is going to be different to how you might deal with maladaptive. All of the broader things around the program will still hold true. You know, being able to make sure we can validate how someone's experience, making sure we can do a thorough physical assessment, making sure that we can get an appropriate diagnosis, making sure that we can set goals, making sure that we can do activity modification, making sure we can tap into the other general benefits of physical activity like aerobic exercise. How can we get that in? Everything that we've covered in this course so far, except that we would have the added specific component of this is a nerve root. What can we do for this nerve root to help calm that down? Okay, and yeah, you will have access to that session. What I'm going to share with you now is the nice guidelines for low back pain and sciatica, where your patient, I would get my patients to be able to print this off to help them find an evidence-based healthcare professional. And it will help inform the questions that they should also ask. Okay, so your healthcare professional should talk with you about your symptoms and how they affect you from day to day. They should check that pain isn't being caused by other problems. So this first part is basically saying you're going to do a thorough physical examination. Okay, and then you're going to do a report of findings that's going to normalize what is going on. And that's what we've sort of talked about here, and being able to normalize the fact that nerve root pain is often maladaptive because of the extent of and everything we just talked about. That is a really important first step, and that's going to then lead into your exercise and physical activity or your rehabilitation. So from everything you guys have done last year, there was one session that we taught that is a really helpful one with the clinical reasoning of being able to move nerves independent of other tissues, to be able to use phrases like lotion is motion, and being able to get that into a nerve root that has been injured or has got inflammation around it. What exercises am I making reference to here that you might want to be able to include as your early calming down sessions with people with radiculopathy or nerve root pain? Whole session, I think maybe even did 2 sessions on it last year in functional management. Magnet spinal wave. Okay, I would use probably those in terms of my clinical reasoning would be around not movement, as what we did last week, or being able to get someone to be able to have relaxed movement to break muscular tensions down. There's probably a much more that's a nice and innovative way for you to be able to play with as a concept. There was something maybe much more conventional, if you want to use that word, in terms of an exercise protocol for moving nerves. Flossing, awesome. Okay, and flossing will one in terms of the category of how we taught that. How might you test a median nerve? How might you move a radial nerve? How might you move a peroneal nerve? How might you move a tibial nerve? Neurodynamics. Okay, it's a session that we went through. You've got it. It's as part of some of your orthopedic tests, but being able to try and differentiate the tissues. So using, if we're talking about a median nerve, we can tension it from this end with lateral flexion, but we can also go into supination and tension it from this end. And if we do that on both ends at the same time, that's going to be a tensioner or a slider. Both ends are being tensioned, being pulled. That's going to be a tensioner. With someone who's got a pissed off, irritated nerve root and radiculopathy, are we more likely to want to tensioner, or are we going to potentially want to take the tension off one end and then floss? Being able to get some gentle movement of the nerve. So at the nerve root, we can move the nerve and you had some videos last year by, name's eluding me now, not Mick Thacker, something like that. Paul's put the video on where we do it with bands, and you can move a nerve root like up to an inch. And with a nerve root that's irritated, being able to do sliders in a nerve root is going to be a really useful, specific exercise that you can be doing with your patients. So if you're doing it for the lower limb, you've got your slumps, or you've got it in a stretch where you're able to bias the peroneal nerve or the tibial nerve, bringing the head in, and sliders could be a really nice, specific nerve root exercise that you can be doing with your patient to be able to get the clinical reasoning of motion is lotion. These nerves want movement just as much as the rest of your body, and we need to be able to touch it, nudge it, tease it. We need to be able to find where you're at and be able to gradually get going. Okay, being able to get that as the specific component to the nerve root, but then the general benefits of all the rest of the things that we've been talking about for descended inhibition, for stress physiology, for novel movement, all of those things can then be used at your disposal for how you might put an exercise program around the first things that you might do, which is the specific things for a nerve root in this instance. Okay. You will want to have adjunctive over-the-counter discussion maybe about medication that their GP is supporting. You know, anti-inflammatories could be really helpful if we've got an inflammation going on around the nerve root, and this should all be done before further investigation into steroids and potentially even surgery. But for the risks associated and the costs, we want to, and we've researchers there to show that we put this package of care together, we can give someone the best chance of not having surgery, and generally people will only be offered 2 or 3 injections of about 3 months apart, but that takes you up to about some symptomatic relief up to about the 9 months to a year, and that's how we can be trying to support someone through great exposure back to what's important to them, even in the presence of a specific in your 5 to 10% would be a nerve root. Also bringing in all of the things that we've covered so far, and I've been saying as we've been going through that these things are maybe directed towards towards persistent pain, because that's far more difficult to work with than acute pain, but they're relevant for acute pain as well. Okay, and that's important. Working with acute tissue-based injuries is straightforward. Stop doing the provocative movement for a while, tissue healing phases, and then gradually get going. Ensure that your patient will want to have, you know, why have I got my radiculopathy? Your assessment and your report findings could be addressing this. To other questions that would include, how can I reduce the effects of pain here on my daily life? That's where that segues into all of the other things that you have been working with me: sensitive alarm, tissue damage and pain, stress physiology, peripheral sensitization, all of the sessions that I've put on Blackboard that I've gone through collaborates with you, but also I've filmed that I filmed as a patient resource for time management, so that you could use that link to be able to send a discussion of me talking about tissue damage and pain, because I have to do that because I don't often have time to be able to be doing it in person. So if I can send them a 10-15 minute video to watch, it means that we can just make sure that we can have a discussion around questions when we're together in person. But next session, we're going to do the final one in terms of giving you the clinical reasoning for outside and around the calming and sensitizing. The person-centered approach will be emotions and pain. So how different things can fill up our metaphorical cup to impact our nervous system turn up or turn down, whether we have non-specific low back pain or whether we have neuropathic pain. Hopefully you can see these connections and start being able to, you could have changed this nerve root that I focused a little bit more on today and change that to knee tendinopathy. Except there would be a graded loading that would go with the knee tendinopathy. We're going to be doing that next year. Okay, so I will upload these things onto Blackboard in this session, and I will speak to Paul and see if I can get, so it's all nice in one place for you, so I can get some of the Mckenzie stuff in this session as well. But this session will then look quite big, but that's going to be a great resource for you. The aches and pains guide is going to be there. We went through neurogenic inflammation from your pain neuroscience education cards there today, and I shall see you guys next week. Adaptive, maladaptive pain. That was the main takeaway from here.